All right, let's talk about necrotizing fasciitis because this is a true surgical emergency. So patient comes in and this really is going to be a assessment on your physical exam that's going to push you to the operating room here. And the pathognomonic thing is like dirty dishwater, which sounds gross, coming from the wound. It's very much a pathognomonic thing. You're going to see that on a test, that a wound is draining dirty dishwater, and that is a immediate reason for you to consider that this patient has necrotizing fasciitis, okay? So there's erythema, there's underlying bad cellulitis. This has progressed from the subcutaneous tissues deep to the fascial layer now, okay? And the fascia is actually dead or dying. So there's different things that can push us towards the OR: white count, lactic acid, sodium, hemodynamic instability. Of course, as I always say, there's a reason why we call them vital signs. So they're going to be tachycardic, they're going to be hypotensive, they're going to show signs of septic shock because they have a necrotizing infection. We're going to talk about something in the next discussion called a Lynn-Rick score. So this is the laboratory risk indicator for necrotizing fasciitis, Lynn-Rick score. We're going to talk about that next. So this patient needs to go to the operating room for an aggressive wide surgical debridement. And how do you know how far to continue your incision and your debridement? Well, you literally can run your fingers through that dead tissue, and until you can't go any further, that's where you need to go. You need to be super aggressive, and this patient absolutely must go into the OR. That's another, what we would call, again, a clean kill. If you don't spot this on a test question and you don't take them immediately to the operating room for debridement.